Dear colleagues, good morning. It's a pleasure to present you this conference about the management of immune-related adverse events induced by immune checkpoint inhibitors. I'm Professor Olivier LAMBOTTE. I'm a clinical immunologist working at Paris-Saclay University at Bicêtre Hospital. So, the rest. Immune checkpoints are major molecules involved in our immune system. They play a major role to limit the activation of the immune system, and they interact between T lymphocytes and myeloid cells. They play a physiological role to switch off an immune response when it's finished, and they have to avoid immune autoimmunity. In the setting of cancer, you have this scheme. You have the cancer cell here in violet, which express some ligands of immune checkpoints, such as PD ligand 1. And when the anti-cancer T cells arrives into the tumor, it is an activated cell, so it expresses PD-1 on its surface, but you have the interaction between PD-1 and PD-L1, and the cancer cells deliver stop message to the T cells. If you use monoclonal antibodies, which are able to remove the interaction between PD-1 and PD-L1, you relieve the anti-cancer T cells, which is activated and which is able to kill its target. So these mechanisms are very potent, and they have been tested in many types of cancer. Interestingly, the immune checkpoint inhibitors are clearly a new strategy. We have learned at the medical school that we can try to kill tumor cells using radiotherapy, chemotherapy, but with the immune checkpoint inhibitors now, you target your own immune system, and you give the ability of your immune system to do the job properly and by itself to kill the cancer cells. Clearly, we have a promising activity in oncology with these molecules. You have here the indications in 2022 in France for the different cancers for which you can use different immune checkpoint inhibitors, which are present here in the box. We have today the capacity to use CTLA-4 inhibitors, ipilimumab, PD-1 inhibitors, PD ligand 1 inhibitors, and LAG-3 inhibitors. In fact, many people are affected by these cancers. If you look at the indication, breast, lungs, bladders, endometrial, etc. So many people are treated, and of course, we have to know how to manage the toxicities of these drugs. At the beginning, the patients who received these treatments were metastatic patients. Because of the efficacy of these drugs, now patients are treated in adjuvant settings and also in neoadjuvant settings. Neoadjuvant here means that you have here lung cancer, which cannot be operated. You give 2 infusions of nivolumab, and you recover the capacity to remove surgically the tumor. And for some patients, just with 2 infusions, the cancer cells have disappeared. You have here on this picture the overall response rate with monotherapy. You can see that the ORR were rather heterogeneous. With Hodgkin disease, you have nearly 70% of response, contrasting with less than 10% for the cancer at the bottom here. This explains why the strategies in oncology have varied a lot, and now these treatments are given in combination. You combine chemotherapy and immunotherapy, for example, in lung cancer, targeted therapies and immunotherapy in kidney, or 2 immunotherapies. This can get higher response rates from aggressive tumor, metastatic tumors, and prolonged responses. This scheme described the different trials some years ago, combining anti-PD-1 plus something else, more than 200 combination. The problem is that the efficacy of the immune checkpoint inhibitors is not specific. We have the risk to relieve these breaks also on autoreactive T cells. So you induce potential autoreactive T cells which can be able to attack your organs. And this is exactly what we don't want to, and this is why we have to learn how to manage these complications. 2 slides to give you just a global picture. The first one here with the anti-CTLA-4 ipilimumab. You see that about 70% of the patients receiving 1 infusion or more of ipilimumab will develop unenumerated adverse events, IRA, enumerated adverse events, and including about 20% with severe grade 3 to 5 IRA. Just to remind you, what does it mean? If we grade the toxicity, the severity of the toxicity, grade 1 means just one rash and you stay at home, no problem. Grade 2, you stay at home, but it's a bit disturbing. Grade 3 is sufficiently severe, you have to go to the emergency unit. Grade 4, you have blisters and blood and you are in the intensive care unit. Grade 5, you're dead. So you can see that with ipilimumab, we have clearly a rather high frequency. Here it is the percentage, the circles, with digestive toxicity. You have also skin toxicity, hypophysitis, and other kinds of toxicity. But the severity due to ipilimumab is very important because you have between 20 to 34% of patients who will require an intensive care unit. If you look at anti-PD-1, 80% of the patients will have an ARA, but only 10 to 15%, and it is in accordance with this large review, will require an ICU. The percentage are different. We always have gut toxicity, but they are less frequent and less severe. But we have more neurologic toxicity with anti-PD-1. We have lung toxicities with pneumonitis. We will speak about that later. Of course, if you combine two immunotherapies or one immunotherapy and one chemotherapy or TKI, you add the toxicity. This is the example here with the melanoma. 7% of toxicity with nivolumab. We speak about grade 3-4 adverse events, nearly 19% with ipilimumab, and nearly 40% with the combo. It's exactly the same here with cytotoxic chemotherapy and lung cancer. I will speak now about each toxicity. If we look at the skin toxicity, nearly 40 to 50% of the patients will develop a rash, something in the skin, with anti-PD-1 and anti-CTLA-4. Toxicity of anti-PD-1 and anti-PD ligand 1 are the same, clearly. We can see all the kinds of eruption, rash, which have been described, so they are not specific. Severe toxicities such as sweat syndrome, vasculitis, Stevens-Johnson are very rare, less than 5%. And the treatment is always to stop the immunotherapy if you have a grade 2. In fact, you suspend it. We will speak later about reintroduction, but grade 2 you stop the treatment and you add steroids, and in skin toxicity we use dermocorticosteroids. So this is clearly what our colleagues dermatologists do. We can have severe toxicity which require oral treatment. If we speak about gut toxicity, digestive toxicity, it is a real problem with ipilimumab, 30 to 40% of the patients. It's less frequent with anti-PD-1, PD-L1, about 15%. But this means that these drugs can induce a kind of inflammatory colitis, which can be ulcerative. And if you don't treat the patients aggressively, the risk is to go to complications like peritonitis. Interestingly, with anti-PD-1, there is a specific colitis, which is microscopic one, and this colitis is difficult to diagnose because if you don't ask the endoscopist to systematically biopsy the colon of the patient, you can miss this microscopic colitis. The etiologic investigation are very important. For all these toxicities, it is the same way of thinking. You have to think about the differential diagnosis. You have to check for Clostridium difficile, and the two exams are the rectoscopy, and which can allow to perform biopsies, and abdominal CT scan, which is important for the prognosis. Treatment at grade 2 is corticosteroids, 1 mg per kilo per day. If you are grade 3 or more, you can do pulses of methylprednisolone, about 1 mg/kg per kilo also. And if the patient does not answer, if you have the colitis is unresponsive to corticosteroids, at day 5, so it's very short time, you add infliximab, anti-TNF-alpha, to break the colitis. You have in green the definition of each grade 2 for you. Liver toxicity, about 5%. You can see every features, cytolysis, cholestasis, mixed profile. The danger is the decrease of the prothrombin time, of course. And in these symptoms, which are most often biological ones, the etiologic investigation is absolutely crucial because there are many causes of increase of liver enzymes. So you must check for viral hepatitis, other drugs, different situations which can contribute to the disturbance of the liver biology. This could require a liver biopsy. The treatment at grade 2 is again corticosteroids 1 mg per kilogram. And if the patient is unresponsive, mycophenolate mofetil is the drugs of choice. Endocrine toxicity, about 10% with ipilimumab, 20 to 30% with anti-PD-1, PD-L1. Some specific features, typically hypothyroiditis, are much more frequent with ipilimumab. It's also the case for type 1 diabetes. Thyroiditis is very, very frequent with anti-PD-1. Hypothyroiditis is also possible, but it's less frequent. The problem, the difficulty for endocrine toxicity is clearly the major symptom, which is I'm tired. Fatigue is a very common symptom. If the oncologist or you don't hear, you don't listen what the patient said, I'm unusually tired, it is a problem, and you can miss some severe complications such as adrenal insufficiency, severe hypothyroiditis, for example. These toxicities are most often unreversible. So always consider endocrinopathies, assess TSH and cortisol if induced, brain MRI if there is a suspicion of hypophysitis. If you give hormone replacement, start by steroids, and regular TSH is clearly required for these patients for their management. Lung toxicity is clearly something which is potentially extremely severe, and we can get some delay in the management, and this is not a good thing. We have to think about lung toxicity in front of worsening or new onset of cough or dyspnea and increased oxygen requirement. This toxicity is defined by CT scan patterns. The lung toxicity is mainly interstitial syndrome, and you can have here all the different interstitial pneumonitis which have been reported in a textbook of medicines. Clearly, complication like organized pneumonia or non-specific interstitial pneumonia are frequently reported, but you can see everything. Clearly, again, the differential diagnosis is very important, and the point which is important to know is that the median time to onset of the lung toxicity is broad, between 5 to 30 weeks, so we can have severe lung toxicity even after several months of treatment. So these toxicities occur later compared with digestive-1 heart toxicity, for example. Usually, these toxicities are reversible, but it's not systematical. The etiological assessment is mandatory, especially to rule out infections such as influenza, pneumocystis. The exams to be done are the CT scan as a first suspicion, pulmonary function tests, but it's not easy to get them, and bronchoscopy if grade 2. This is an important message. We strongly recommend to perform bronchoscopy without delay. So if you are in front of the patient, it's absolutely possible to start both steroids and community-centered antibiotics to cover both the lung toxicity and the infection. I will speak about that later, but it's useful, and it has reduced the percentage of death we had in our center. Arthritis, joint toxicity, yes, it's possible. Arthralgia, myalgia, about 15%, 10 to 15% of the patients will have arthralgia and polyarthritis. The polyarthritis are either rheumatoid-like but seronegative. You can have also polyarthritis associated with psoriatic form, and you can have also PMR. The management of the joint toxicity is mainly based on NSAID or low dose of steroids. They are not associated with severe toxicity. It's very different if compared with the muscles. Myositis, myalgia are much more dangerous because they can associate with difficulty about the diagnosis, and this is a good example here with the description of focalized myositis, here localized only to eyes muscles, or here just only for the spine muscle. So these presentations are clearly unusual and can be missed by the physician. The second danger for the myalgia and myositis is the association with pseudomyasthenic forms, and mainly the warning is myocarditis. About 1 by 3 patients with myositis will have the triple form, which is more severe, with myocarditis and myasthenic syndrome. Myocarditis is clearly rare, but it's a deadly form if you don't treat it very aggressively. You can have different complications, troubles of conduction, pericarditis, etc. Troponin is mandatory as an electrocardiogram. Heart echography is not a good exam in this situation, and the MRI, heart MRI, is very important, but it can be normal during the first days of your management, and you will have to repeat the MRI. If you have combo, Nivo plus anti-PD-1 plus ipilimumab, you increase the risk of myocarditis. The treatment is steroids very fast, as we'll show you. In any doubt, you give high dose of steroids in emergency in ICU. So put the patient in intensive care unit and start strong doses of steroids. There is nearly no differential diagnosis except cardiopathic ischemia. The differential diagnosis is coronaropathy with infarctus. Except that, there is no differential diagnosis. If you get late, you have possibility to perform autopsy and interesting immunological study, but unfortunately the patient is dead. So clearly consider rare toxicity, but it's probably underestimated. Non-specific presentation, yes, but think about that. All cardiac manifestations are possible. Cardiac MRI, I told you. There is a question of the screening. Is it necessary to perform troponin measurement before each infusion of anti-PD-1? Clearly there is a question of money for that. I don't have any answer about that. Beware of the myocarditis, myositis and myasthenia association, and if you get some delay, it is often fatal. If you treat fast, you save the patients. Here you have the experience of a big center of cancer in the US. It's interesting because you have a high number of patients, more than 9,000, only 36 with myositis, and 2 groups, the group of isolated myositis with nearly 50% of survival, and 19 with the overlap syndrome with myasthenia and myocarditis. And in this group, in gray, you have 8 deaths, all in this group, and despite different treatment received. This French study tried to find the best treatment for this myocarditis. Some interesting messages. First point, 36 by 60 patients received therapeutic intensification. This means steroids plus something, but interestingly, 24 didn't need anything more. These patients had combination. Clearly, the combination anti-PD-1 plus anti-CTLA-4 is GGR use, and they were also associated with the triple form. Interestingly, only 8 deaths were related specifically to the cardiac causes. Known drug was identified as the best, but one drug is clearly deleterious and must be avoided, which is infliximab. This slide is very important. It gives you the evidence that if you give high steroids dose fast in the first 20 hours of diagnosis, you get a very good survival. So today, for me, all the patients with myocarditis must have first 3 bolus of methylprednisolone. In contrast, indeed, if you give low dose of steroids, it means less than 1 milligram per kilogram, and with a delay, the burden of mortality is very high. Neurologic toxicity, less than 10%, some complications which are not very severe, such as neuropathies or asymptomatic meningitis, contrasting with Guillain-Barré, myasthenia, or encephalitis. Again, the etiologic investigations are very important because you have to rule out cancer progression. You have to rule out paraneoplastic syndrome, especially with autoreactive antibodies, which are targeted the neurons or the synaptic proteins. So clearly, this point is very, very important. Track paraneoplastic syndrome and cancer progression. After saying that, you perform your work as usual: MRI, lumbar puncture, electromyogram, and steroids as soon as you have grade 2 and above. Time is moving on. So along the time, we have been able to identify the identification of real autoimmune disease or inflammatory disease, such as type 1 diabetes or Sjögren's syndrome, or some cytopenia for autoimmune disease, and for inflammatory disease, psoriasis or granulomatosis, which are clearly sarcoidosis. An important point: the delay of occurrence of these toxicities. Look here at the combo. You have the start of the immunotherapy at the beginning of the axis. Clearly, these toxicities occur between the first 4 months of treatment for ipilimumab and the first about 2.5 months for anti-PD-1. So it's not immediate. You have here the median of appearance. Clearly, an early toxicity after the first cycle is clearly unusual. It can occur, it's true, but it's really rare. So in front of a symptom which can be a toxicity after the first infusion of immunotherapy, be careful, it's probably other thing, another diagnosis. 70% of this toxicity will resolve after immune checkpoint inhibitor stop, and the median of resolution is between 1 or 2 months. Importantly, occurrence of new immune-related adverse events even after the stop of the immunotherapy are possible. New toxicities can appear on treatment even a long time after the start of the treatment, but these toxicities can also occur after cessation of the treatment, so be careful about that. We published this pathway to try to help clinicians. If we speak about the prevention or anticipation of IRAs, clearly to have an autoimmune disease is a risk factor to develop an IRA, so this is something which is important, and this picture showed you that here in this trial, nearly 50% of the patients with an autoimmune disease will have a flare and or an IRA, so a flare of their own disease or something else. It depends, there is no rules. But the important point is that we didn't see any difference for the overall survival. So to get an autoimmune disease, to have flares, is not associated with higher morbidity and mortality. And this work was confirmed by our Netherlands Dutch colleagues in the huge register of melanoma in Netherlands. And as you show here, more than 4,000 of patients, more than 200 with autoimmune disease, no difference in the incidence of severe IRA, and no difference in the overall response rate and the survival. So clearly today, an autoimmune disease is not a contraindication to receive an immunotherapy. Of course, you can discuss about that in toxicity board, which are clearly very important tools, but we cannot refuse the access to this treatment just by the fact that there is an autoimmune disease. May we predict IRA? There are many works, clinical research work about that, with genetic screening, looking for autoantibodies which can predict toxicities. This is the case probably of anti-acetylcholine receptor antibodies and myositis, but it's, to my opinion, the alone which can be interesting. Role of microbiota, and there are some discussion about the association between anti-tumor efficacy and the development of IRA. Clearly today we know that if a patient develops some immune-related adverse events, it is associated with a better prognosis and a better response of the treatment. Very important today at the bedside to continue to have a thorough medical history of the patients and to follow the patient for a long time. Patient education is very important, and also, of course, in mirror, listening to the patient by the oncologist. About now, try to anticipate any toxicity. Do we need to perform some specific exam? The answer is no. We have only to check the functions of the main organs targeted by the main array. So you have the list here. We need cortisol TSH, we need an electrocardiogram, we need a CT scan for the lungs and respiratory functions, the biology for the liver, the urinary dipstick for the kidney, it's very useful, and creatinine, CK for the muscles, the hemogram. Important to check for the hepatitis C, B, and for HIV. And for autoantibodies, there is no indication today to perform autoantibodies before starting immunotherapy. To anticipate now patient education, yes, it's important, listening to the nurse oncologist, the new role of coordinator nurses, and digital tools. To detect, clearly we have to think different. A new symptom in a patient treated by immune checkpoint inhibitor is not systematically an ARA. Of course, we have to look for the possibility of an immune-related adverse events, but unfortunately it is often the cancer, and some unrelated causes are often present also, typically flu or COVID during the winter, with patients coming at the ICU with an interstitial lung syndrome. There are a major need to train oncologists, intensive care physicians, GPs, other specialists, but also chemists, radiologists, nurses, and the patients to learn about these treatments. There are progresses, clearly, especially, for example, for the intensivists, but some specialties remain poorly informed. To treat, we continue the immunotherapy of grade 1, we suspend at grade 2, and the treatment is usually prescribed at grade 2 and more. Corticotherapy is tapered rather rapidly for between 4 to 6 weeks. So it's not a prolonged duration of steroids. At 3 to 4 months, the steroids are stopped. Do we reintroduce the immunotherapy? You have stopped the immunotherapy because of grade 3. The patient is treated for his IRA. The immune-related adverse event is fully resolved. Can I restart? The answer is yes, it's possible. After the discussion in Toxicity Board, in our publication here, we saw exactly the same features compared with patients with autoimmune disease. One patient by 2 will develop either the same IRA or another one. But there was no more morbidity, neither mortality, no death. What about the steroid unresponsive IRA? It's a difficult question. If you have colitis, infliximab and also vedolizumab are clearly requested. Avoid tocilizumab because of risk of gut perforation. In the setting of pneumonitis, we don't know. There are propositions about cyclophosphamide, mycophenolate mofetil, intravenous immunoglobulin. We don't know, clearly. About encephalitis, it's probably the last indication for plasma exchanges to epurate autoantibodies. Intravenous immunoglobulins are used, rituximab often. In very severe forms, natalizumab could be useful. In the setting of myositis, intravenous immunoglobulins are useful. Methotrexate, rituximab can be used. About myocarditis, there is no rules. Clearly, you must avoid tocilizumab and anti-TNF because anti-TNF is deleterious and tocilizumab does not seem to give answers in different publications. In the US, mycophenolate mofetil is largely used. In France, ruxolitinib and abatacept is suggested by one team in Paris at Pitié Hospital. Clearly, we recommend ruxolitinib alone. We don't give abatacept at Gustave Roussy in our network. Our oncologist colleagues are not very okay for that. Ruxolitinib alone works well, and if we are completely blocked, we use tacrolimus intravenously for the very extremely severe form, and it works also. But the main message is you must discuss about these cases. You must discuss with expert groups to define the best treatment to get. Challenges, yes, there are some challenges. The main challenge for us is early detection to avoid therapeutic delay. It was the case for in our network. Clearly, we had a heavy burden of respiratory complication and death, And this is clearly because we performed the bronchoalveolar lavage only after getting all the data, and we delayed the steroid administration for these patients. Clearly we have changed now when we give steroids much more rapidly. To finish, do we have other risks? Yes, there are some risks about the risk of immunosuppression. About the loss of efficacy, as I said, no. There is no deleterious risk of loss of efficacy with steroids. We don't know for immunosuppressive drugs. It's more we don't have more data about that. The infectious risk is present, especially if you have combo, because it is the most toxic association. The main message is, if you have a patient with an IRA which is treated with steroids and or immunosuppressants, and the patient goes well, but you have a re-aggravation some days or some weeks later, you must track a super infection. It should be an infection. It's much more likely that a relapse of the toxicity. So be aware of infections. Okay. In the daycare, some tools. Clearly, most of the cancer centers use a network of organ specialists to help oncologists. This is something which is extremely valuable. So if you don't have this network of organ specialists, set up it. I would like to thank my colleagues at FAI² University and Gustave Roussy. Second point, you can set up a registry, and we have a prospective registry at Gustave Roussy, which allows us to perform prospective study with more than 4,000 patients. And third tool, set up a multicentric national assessment board. So it's a very important point. To set up an assessment board for the management of these toxicities is now very frequent in the different hospitals with Department of Oncology. If there is not in your hospital, clearly the oncologist should set up such an assessment board to discuss the difficult diagnosis. You have the description on the slide with the contact for if you want to contact us. We also set up some expertise center, and we would like also to underline the importance of the education of patients and caregivers with the creation of diplôme universitaire and d'immuno-oncologie and the ETOX symposium, which are set up for all in May month each year. In conclusion, immunotherapies are a revolution in oncology. Oncologists and all practitioners clearly must think differently in front of an expected or unexpected symptom, and clearly patients with lung cancer treated by immunotherapy coming for dyspnea and cough. It can be the progression of the cancer, but it can be also the toxicity of the anti-PD-1. It's urgent to set up different tools around the cancer centers. Importance to strengthen the patient-caregiver communications, the self-reporting tools which are in process, importance of the training, and clearly it is an important research field for the different mechanisms of immunotherapies for the efficacy against the cancer and for the management of the toxicities. I would like to thank you, and to thank all the people with whom I have the luck to work, and don't hesitate if you have a question to send me an email about that. Thank you.